Assalamu alaikum. Dear students, I will talk today about the history and examination of urologic patient. I will start with urological symptoms in general. And during history taking from urologic patient, as you know, the urology is the science that deal with disorders of urinary tract and genital disorders of the male patient. During taking a history from any patient with urologic complaint, just like any history, it is the cornerstone for evaluation of any patient with any complaint, including urologic patient. Complete history is divided, like any history, to chief complaint, history of a present illness, past medical surgical history, drug history, and family history. The most common neurologic complaints or symptoms the patient presented with include pain, change in the act of micturition, change in gross appearance of urine, change in function and or appearance of male genitalia, and systemic symptoms. Regarding the pain arising from genitourinary tract may be quite severe and is usually associated with obstruction, inflammation, or due to tumor that usually do not cause pain unless they produce obstruction or pressure on adjacent nerve. So, pain of urologic origin most likely arises from inflammation of urinary tract or obstruction of urinary tract. Obstruction like ureteric obstruction by anything like stone, clots, papillary necrosis, obstruction from within the wall by stricture, tumor, polyp, or obstruction from outside the wall like a pressure from adjacent cyst, a tumor, or collection. Inflammation of urologic organ also cause pain, especially solid organ like the kidney, prostate, testis, and epididymis, which is called parenchymatous organ inflammation, produce severe pain like pyelonephritis, prostatitis, epididymitis. Inflammation of mucosa of hollow viscus, such as the bladder and urethra, usually produce discomfort only, like suprapubic discomfort during cystitis. Renal pain. Renal pain is usually located in the costovertebral angle, which is the space between the last rib, 12th rib, and the paraspinalis muscle. This angle is called costovertebral angle, which is located in the flank, upper part of the flank or loin. Pain of renal origin also may be due to inflammation or obstruction. Inflammatory pain usually steady, dull in nature, usually due to distension of renal capsule by inflammatory process like in pyelonephritis or rapidly enlarging cyst or tumor that cause intratumor hemorrhage or necrosis and rapidly distend the renal capsule. While the pain of the kidney due to obstruction usually intermittent, fluctuate in intensity, called colicky pain. So it is called renal colic. May be associated with characteristic symptoms. Renal pain may be associated with other symptoms like GIT symptom, most likely upper GIT symptom as nausea or vomiting, usually due to reflex stimulation of celiac plexus, which is sharing nerve supply between the kidney and the upper GIT stomach and the duodenum. Also, renal pain has a characteristic radiation from the flank toward the anterior, upper abdomen, umbilicus, groin, and even reach the external genitalia as scrotum in male and labia in female. Differential diagnosis of loin pain or flank pain include urologic disorders as renal inflammation or renal obstruction, but also it may include other systems like intraperitoneal pathologies, appendicitis, pancreatitis, cholecystitis, diverticulitis, peptic ulcer, all may cause flank pain. The difference is that characteristic radiation of intra-abdominal pathologies is usually toward the back or opposite to site of origin, whereas the renal pain radiate toward the groin and external genitalia. And also the site of greatest pain and tenderness usually in the epigasteria or right hypochondrium, not the flank or costovertebral angle. Also, there may be radiation or referral of pain toward the shoulder due to irritation of undersurface of the diaphragm by fluid collection or inflammation, may cause irritation to undersurface of diaphragm and phrenic nerve and cause pain felt in the ipsilateral shoulder. Other system that may cause flank pain is the musculoskeletal system with irritation to intercostal nerve and lumbar plexus or sacral plexus due to pathologies within the vertebra. Also may cause flank pain with characteristic radiation, but here the radiation toward the lower back or toward the thigh and leg, like sciatica pain. This pain is called radiculitis or lumbago, like musculoskeletal spasm, usually from irritation to the nerve from T10 to T12. However, the pain is usually continuous and it's enhanced or increased or aggravated by mobility. And just opposite to the flank pain, which is the patient may get benefit from writhing in agony and continuous mobility. Urethral pain, pain of the ureter is usually due to obstruction of the ureter because the ureter is a tube-like structure and hollow organ. So obstruction of this hollow organ may cause acute, sudden, severe pain, just like ischemic pain due to severe contraction of smooth muscle of the ureter during peristalsis over the site of obstruction, causing severe acute pain. And this pain is usually intermittent, colicky in nature, with also characteristic radiation. So in the obstruction at the level of upper ureter, it may cause just like renal colic pain with referral to the groin or genitalia. Mid-ureter may refer on the right side to the right iliac fossa, McBurney point, and which simulate acute appendicitis, and on left side to the left iliac fossa, resembling diverticulitis. Lower urethral obstruction may cause pain that refer to the labia or scrotum or even medial side of the thigh, and usually associated with lower urinary tract symptoms as dysuria, frequency, urgency, or suprapubic discomfort. Vesical pain. Most of the bladder pain usually due to inflammation of the bladder, which is hollow organ, so it causes suprapubic discomfort, usually associated with urinary symptom as dysuria, frequency, and urgency, or hematuria, but no fever. But it also may be the result of retention of urine, which is cause acute, severe, sharp suprapubic pain with severe urge to pass urine, but there is no urine output. For several hours, it is characterized of retention of urine, and during examination, we feel distended bladder mass-like in the suprapubic area, which is dull to percussion. Prostatic pain. Prostate is a parenchymatous organ, solid organ. The pain of it usually due to inflammation of the prostate, and that cause edema and distension of prostatic capsule, which is the cause of pain. But the pain of the prostate is poorly localized because it's supplied mostly by autonomic nerve. It may be felt in the perineal area, in the perirectal area, perianal area, in the groin, in the suprapubic area, in the penile shaft, and it's usually associated with lower tract symptom as difficult in voiding or dysuria or pain after ejaculation. Penile pain. Penile pain divided into pain during erection and pain during flaccid penis or pain in the flaccid penis. So according to the state of the erection, pain of the flaccid penis is usually due to disorder of the urethra as urethritis, while pain during erection mostly due to priapism, which is a persistent sustained erection without sexual stimulation for at least 6 hours, and this is called priapism. And also it may occur in Peyronie's disease, which is a fibrotic patch involved the tunica albuginea that cover the cylindrical body corpora cavernosa, so that during erection it may cause pain in the erected penis. Scrotal pain can be acute or chronic. Acute pain usually due to acute condition within the scrotal content as epididymitis, epididymoarchitis, or torsion of the spermatic cord and ischemia, torsion of testicular appendages, acute hematocele, collection of blood between the layer of tunica vaginalis due to trauma, pyocele, which is a pyogenic infection of the collected fluid between two layers of tunica vaginalis, which is called hydrocele. Or it can be chronic, which is called chronic orcalgia, and it's usually due to disorder of like varicocele, hydrocele, epididymal cyst, spermatocele, and sometimes it's of neurologic origin due to referred pain from inguinal canal in patient with inguinal hernia, referral from the kidney, from the ureter in patient with ureteric obstruction. This is all about the urological pain. Now about voiding symptom. Voiding symptom, the symptom that occur during the act of micturition, during voiding. It can be divided into irritative symptom and obstructive symptom. Regarding irritative symptom, the most frequent irritative symptom is the frequency. Frequency is the daytime increase in the number of voiding or urination more than usual. So an adult patient, void of 5 or 6 times per day is normal, with a volume of approximately 300 ml per each void. So frequency due to either increased urine output, polyuria, or increased irritability of the bladder, which is called detrusal instability, or due to decrease the capacity of the bladder, such as in neuropathic bladder. All these may cause frequency. Nocturia is the frequency at the time of sleep, so it's called nocturnal frequency. Normally, adults arise no more than 2 times per night, or according to the habit of the patient. So if the patient habit to arise from sleep 1 or 2 times per night, if he arises more than 2 times, it's regarded as nocturia. Nocturia occur in a patient with congestive heart failure or peripheral edema for any cause. In old age patients, due to decrease the elasticity of the bladder, or during drinking a lot of fluid or diuretic at bedtime or night, all these may cause nocturia. Also, a renal impairment, loss of concentrating ability of the kidney, the patient may develop nocturia. It is also the earliest symptom of prostatic hyperplasia. Dysuria is painful or scalding urination, commonly referred from the suprapubic area toward the urethral external meatus. At the start of urination, it indicates urethral pathology. It's called initial dysuria. At the end of micturition, terminal dysuria, or what we call strangury, usually indicate bladder origin of the pain. Dysuria is frequently accompanied by frequency and urgency. What's urgency? Urgency is the sudden intense desire to void that the patient cannot defer. So it is severe urge to pass urine, which is if delayed, the urine may pass out involuntarily and cause incontinence of urine. Urinary hesitancy is also a feature of obstructive symptom. It is a delay in the initiation of micturition. So patient will sit for a while, waiting for seconds or minutes to start micturition. It's also from earliest sign of bladder outlet obstruction by enlarged prostate. Decreased force and caliber of urinary stream. There is narrow stream, weak stream due to bladder outlet obstruction by PPH or urethral stricture or other cause of bladder outlet obstruction. Straining, which is mean that the patient use abdominal muscle to enhance the voiding or flow of urine. Intermittency, which is interrupted stream. Intermittency means interrupted stream of voiding. Post-void dribbling refers to the release of a few drops of urine after micturition. Post-void dribbling, patient after completing of the voiding act, he stand and walking a few steps, a few drops of urine will pass involuntarily and called post-void dribbling or incontinence. It's also a sign of bladder outlet obstruction, but also it may occur with neuropathic disease. Incontinence, urinary incontinence is the involuntary loss of urine. It's of several types. Continuous incontinence, all the day, 24 hours, the patient is wet. Most commonly due to a fistula in the urinary tract, usually between the bladder and the vagina, due to gynecological surgery or obstructed labor, trauma, or radiation. Or ectopic ureter that insert distal to the external sphincter to the urethra or to the vagina may cause continuous incontinence in female. Stress incontinence is the loss of urine with the raised intra-abdominal pressure, like during coughing, sneezing, laughing, exercise, lifting heavy weight. Most common in women after childbearing or in menopause or in men after prostatic surgery that cause injury to the external sphincter. So it's more common in multiparous ladies. Urge incontinence is the loss of urine preceded by urgency or strong desire to pass urine. It's mostly due to inflammation of the bladder, cystitis, or due to neuropathic high pressure bladder. Overflow urinary incontinence. This is usually occur in patients with a chronic retention of urine with overdistended bladder beyond the bladder capacity. This high residual urine volume may lead to passage involuntarily of continuous amount of urine that exceed the bladder capacity. It is called overflow incontinence. So it is not a real incontinence. It is an obstructive problem that lead to involuntary loss of the extra volume of urine that larger than the capacity of the bladder. So urine dribble during due to bladder overflow. Enuresis, or what we call nocturnal enuresis, is the involuntary loss of urine during sleep. This is mostly occur in the child age group. It is physiological before 3 years of age, but considered pathological after that age, and it may need treatment after the age of 7. Change in the gross appearance of urine. The patient may come with complaint of change in the color of urine. Most commonly, red color of urine. Most commonly, due to presence of RBC within the urine. It's called hematuria. It's defined as the presence of more than 3 RBC per high power field. Villus hematuria in adult should be regarded as a symptom of urologic malignancy, while painful hematuria usually indicate inflammatory or stone disease. In evaluating hematuria, it can be classified as gross, seen by patient or doctor, or microscopic, seen only under the microscope. Initial, during the initiation of micturition, terminal at the end of micturition, or total, all through. All the urine from the start to the end is red in color. It's also classified, as we said, into painful, which is usually benign, or painless, which may indicate malignant pathology. Associated with the clot or not, and the shape of clot. Most importantly, to ask the patient if there is passage of a solid clot with the urine, and if it is present, mean it is a massive hematuria, profuse hematuria, and usually occur in malignancy or after a trauma. And the shape of a clot may give an idea to the origin of bleeding. If it is a thread-like, it may become from the kidney, and during the passage through ureter, it take the shape of a tubular structure of the ureter. Or if it is irregular and large size clot, it may be from bladder in origin or prostate. Change in the gross appearance of urine also include cloudy color, which is maybe due to presence of pus, white BC, called pyuria, or presence of a crystal like phosphate, which is called phosphaturia. Pyuria usually indicate urinary tract infection with large quantities of white BC in the urine, give a cloudy appearance. Microscopic examination of urine will demonstrate pus cell. And usually these patients need culture and sensitivity of the urine to demonstrate the type of bacterial infection. But pyuria may occur even without the presence of bacteria. It is called sterile pyuria, which may occur in patients with foreign body, like stent, catheter, stone disease, and in patients with TB of the urinary tract, tuberculosis. Phosphaturia due to precipitation of phosphate in alkaline urine. Acidification of urine with acetic acid at the time of urine analysis causes a clearing of the specimen. So, phosphaturia is the presence of a crystal of phosphate that usually precipitate in alkaline urine with pH more than 7.5 due to bacterial, mostly due to bacterial infection of a Proteus type of bacteria, Proteus mirabilis, and acidification of the urine with acetic acid lead to reduction of the pH of the urine and dissolution of the solute. Abnormal appearance and or function of external genitalia. The patient may come and complaining from abnormal appearance of the external genitalia, or there is defect in the function of external genitalia. So, male sexual dysfunction and impotence, or what we call now erectile dysfunction. Impotence is the inability to achieve and maintain an erection adequate for satisfactory sexual intercourse, satisfactory for the male and for his partner. Other male sexual disorder include loss of libido, loss of desire, absence of emission. There is no emission of semen from the seminal vesicle and the prostate to the posterior urethra. Absence of orgasm the patient not reach to the orgasm at the end of ejaculation, and the premature ejaculation, which is early ejaculation before a satisfactory period. Bloody ejaculate, what we call hematospermia, mean a presence of blood or RBC within the semen or seminal fluid. It is almost always a benign condition due to non-specific inflammation of the prostate or seminal vesicle. Very, very rarely it may be due to malignancy of the prostate. Other penile complaint is a cutaneous lesion that affect the external genitalia, whether benign or malignant cutaneous lesion, as a papule, pustule, ulcer, or a rash of the external genitalia. Penile curvature, which is curving of corpora of the cylindrical body of the penis, either congenital penile curvature or acquired penile curvature, for example, Peyronie's disease or after fracture of the penis. Urethral discharge. One of the common complaints, usually infection or venereal infection. Purulent, thick, profuse, yellow or gray discharge is typical of GC. Gonorrheal infection or gonococcal urethritis. Scanty, watery discharge, usually due to non-specific urethritis, usually chlamydia trachomitis. A bloody discharge may indicate a pathology within the urethra, whether benign or malignant, as polyp of the urethra, viral infection of the urethra, or carcinoma of the urethra. Scrotal complaints, as scrotal skin changes, as cutaneous lesion, papule, ulcer, pustule, rash, absence of or retractile testis, absence of the testis or retractile testis, usually due to undescended testis, ectopic testis, or retractile testis. Scrotal swelling or masses, whether benign or malignancy, may be a common complaint of scrotal. Systemic symptom that may be associated with the urinary tract problem, like fever and chills, usually occur during infection of urinary tract, like pyelonephritis, prostatitis, and epididymitis. Fever, weight loss, malaise are non-specific symptoms or manifestation of acute or chronic inflammation, renal failure, malignancy of urinary tract, or without metastasis. Now, this is all about the symptomatology of the urinary tract. Now we will shift to talk about examination of the genitourinary tract. General examination is like the examination of a patient with any complaint. It starts with the appearance of the patient, distressed due to pain. He's appear well or unwell. This may indicate systemic illness and possibly renal failure if the patient is tired with easy fatigability. Complexion, like pallor, usually indicate anemia. It may be due to hematuria, due to loss of appetite, like a renal failure or an advanced malignancy. Vital sign like pulse, blood pressure, temperature, respiratory rate. Blood pressure is very commonly related to disease of the kidney. 5% of the causes of hypertension is renal in origin. Signs of dehydration, dry mouth, tongue, delay in the peripheral perfusion, dry skin, dry mucous membrane may indicate renal failure, may indicate polyuria, such as in diabetic patient, maybe due to repeated vomiting from renal colic or other. Cervical lymph node enlargement due to metastasis from urologic malignancy, such as renal cell carcinoma. Regarding abdominal examination, just like abdominal examination of any patient with any complaint, It starts with inspection, superficial palpation, deep palpation, percussion, and auscultation. Regarding inspection, also we emphasize on the presence or absence of scar, especially around the umbilicus, just like laparoscopic scar, distension, a prominent vein, local swelling, and hernia, pulsation, visible peristalsis, and skin lesion. Exclude lesion of the abdominal wall. Patient raises head. Patient does not. If the patient does straight leg, raising, blowing testis, or Valsalva maneuver, check for inguinal nodal enlargement, such as in patient with disease of the penis or scrotum that drain to the inguinal lymph node, especially malignancy of the scrotal wall or malignancy of the penis. Palpation of the abdomen. Usually we use a warm hand. Examine the tender area last. Light palpation, then deep palpation. Check for guarding rigidity, rebound tenderness. Determine for any mass, any palpable mass. We should comment on the side tenderness, size, shape, surface, regular or smooth edge, regular or irregular consistency, soft, hard, mobility, overlying skin, regional lymph node, whether pulsatile, palatable, bimanually palpable, anything related to the mass. Differential diagnosis of abdominal masses according to the division of the abdomen to 9 region or quadrant by imaginary lines. Specific palpation of the kidneys, kidney by manual examination for renal enlargement or masses. Usually the kidneys are non-palpable because it's hidden deeply under the thoracic cage. Any palpable kidney is abnormal. So with a hand posteriorly lifting up the kidney toward the examining abdominal hand, this is called bimanual examination of the kidney. The kidney, if enlarged, is bimanually palpable and it is palatable. And we should differentiate between a palpable kidney from enlarged liver on the right side and enlarged spleen on the left side. Tenderness over the kidney should be tested by gentle pressure over the costovertebral angle. Bladder palpation, usually the bladder is palpable, felt by the ulnar side of non-dominant hand and by the palm of the dominant hand. Then by percussion we found usually distended bladder as dull percussion to percussion, especially in case of retention of urine as acute or chronic. By auscultation, auscultation is used for buoy of renal artery in patients with renal artery stenosis above the umbilicus and 2 cm to the left or right of the midline, and also on both flank with the patient in sitting position. Examination of the scrotum and external genitalia. The scrotum and external genitalia located outside the abdominal cavity, so they are visible and palpable. Penile examination by inspection and palpation along the course of the cylindrical bodies, along the course of the urethra and the external meatus. Prepuce should be retracted for examination of the glands in patient who is uncircumcised. We should examine to exclude phimosis, which is a non-retractable foreskin, and paraphimosis, which is a retracted foreskin that cannot be returned over the glands. Hypospadias, which is congenital anomaly with subnormal position of the urethra. Any disorder of the glands, skin of the glands and the shaft of the penis For ulcer rash, we squeeze the urethra for any urethral discharge. Examination of the scrotum, usually by manual examination with non-dominant hand in the groin, compressing on the external guinal orifice, and the dominant hand palpate the scrotal content. Inspect the scrotal skin for any lesion. Palpate the testis, the epididymis, the vas, the cord. Identify scrotal swelling with a long list of differential diagnoses according to the associated pain. It is divided into painless and painful scrotal swelling. Is it possible to get above this swelling? If we can get above the scrotal swelling, it is usually not hernia, either hydrocele or varicocele or epididymal cyst or tumor. Is the swelling solid or cystic? The solid swelling usually may indicate a tumor or inflamed testicular body or epididymis. Cystic swelling may indicate hydrocele, varicocele, epididymal cyst, or spermatocele. Is there a hydrocele, varicocele, epididymal cyst? As we say, testing for translucency with a torch in a dim light room for differentiation of hydrocele from other causes of scrotal swelling. Differential diagnosis of common scrotal swelling. We divided it into whether it is attached to the testis or separated from the testis. If it's attached to the testis, we divide it into solid or cystic. If it is solid, non-translucent, it is testicular tumor. But if it is cystic, translucent, it is hydrocele. If the swelling is separated from the testis, the solid one usually indicate epididymitis. The cystic one usually indicate epididymal cyst. Now, rectal examination, it is integral part of abdominal examination and specifically genital examination. Rectal examination is performed to palpate the prostate and anal canal and rectal content and rectal wall. During rectal examination, we assess the external part of the anus for any lesion, pile, abscess, ulcer, fissure, fistula, and after insertion of index finger of dominant hand, we palpate the cavity and the wall of the anal canal and the rectum for any mass, ulcer, any lesion. Then we examine the prostate, which is located anteriorly. The prostate usually of peanut size, of firm consistency, with two lobe, right and left, and a median sulcus. So we examine the prostate for its size, if it is enlarged or not, consistency, if there is increase in the consistency, it is usually firm, but if it is hard, it may indicate malignancy. The surface of the prostate, it is usually smooth and freely mobile over the rectal mucosa. If it is irregular, lobulated, or if it is adherent to rectal wall, it may indicate a malignancy. The median sulcus, if it is deepened, it may indicate a benign enlargement, hyperplasia. If it is obliterated completely, it may indicate carcinoma of the prostate. Tenderness of prostate usually indicates inflammation of the prostate. It is painless, non-tender in malignancy and in normal and benign prostatic hyperplasia. Bladder base may be palpable. If there is a mass within the bladder, there may be adhesion and fixation of the mass or bladder to rectal wall. Anal tone also examined in patients with neuropathic bladder to see if there is underlying neuropathic disease. Anal pathologies, as we said, any fissure, any pile, fistula, and others. A hard area in either or both lobes of the prostate suggests a cancer, and a biopsy is needed to obtain histological diagnosis, so keep in mind. By manual examination, is integral part of patient with a suspected malignancy of the bladder or prostate. In male, the index finger in the rectum and the non-dominant hand in the suprapubic area try to feel the prostate and the bladder base and whether it is mobile freely or it is fixed. Fixation of the bladder indicate advanced carcinoma of the bladder. In female, index and middle finger in the vagina and non-dominant hand suprapubically to see if the bladder is freely mobile or it is fixed, which is a sign of advanced malignancy. This is all about approach to urologic patient regarding the history and physical examination. Thank you.